So I just get wired up again. There we go. Right, can everybody hear me this time? Great stuff. Okay. Okay, good morning, everybody. I've been asked to talk a little bit about sort of local and national perspectives on advanced practice, and I've subtitled this The Evolution of the Advanced Nurse Practitioner Role, because I think if we think about it in terms of evolution, it gives us an idea of why we've got to where we've got to today, and also can give us some thoughts around what that might mean, some of the implications of that. So in case you're wondering, yes, that's me up there. A couple of reasons for that. One is I couldn't get anybody to do that in post for me, so I had to do it myself. And the other reason is I usually find it's better to humiliate yourself first before somebody else gets in there and does it. So that's me. So that's what we're going to talk about. So there's been an awful lot of evolution in nursing. As Auntie Flo put it, nursing used to be left to those that were too old, too weak, too drunken, too dirty, too stupid, or too bad to do anything else. Some of you might not think it changed too much. Abuse is going to start. I can feel it now. But we have moved forward significantly, and that's the definition for an advanced nurse practitioner from the International Council of Nursing in 2002. So it's been around a long time. And that's one of my colleagues from Glasgow. It's Stu Daly from the Emergency Medical Retrieval Service. He's an advanced critical care practitioner in that service, has a background as a nurse, works with paramedics doing the same role. Okay. So, evolution. I think we're all comfortable with the idea of evolution in biology, where you've got genetic information that gets copied. Sometimes you get some errors creeping in, so there's some variation that creeps in. Sometimes that will cause a mutation. So if that mutation confirms some sort of advantage to the organism, then through natural selection, those organisms might get, become more predominant. But can it apply to other things as well? I think it can. I think it can apply to ideas, behaviours, styles. In fact, almost any sort of cultural thing it can apply to. And this was first described by Richard Dawkins in 1976 in his book A Selfish Gene. He proposed this term of a mem. Have you heard that term before? Yeah. So he proposed it as being something that was equivalent to genes in biology, and where you would get some transmission of information. So it has to be subject to variation, to mutation, to competition, to inheritance. So if you think about it as a unit of cultural transmission, so it could be an idea, it could be a behaviour, it could be a style that spreads from person to person within a culture. And good examples of those are things like melodies. You might hear the same sort of melody appearing in different pieces of music written by different people. Fashions, that's another good example, isn't it? Where somebody will come up with a new idea, and you'll see that or copied in different ways in different pieces of clothing. It can also apply to skills learned and internet memes. I think that's probably where we hear that term most often, with internet memes. So you've probably seen that one. Very familiar. Lots of bags and t-shirts and car stickers and all sorts of things. From an original government publication during the Second World War. I think they didn't actually use it very much. I think it was once. But it's out there, and you can see it evolves. That's one of my favourite ones, into different memes. I'm going to stick this one up at work. Okay, so for evolution to occur, there needs to be something allows it to be copied, some variation to occur, and some differential fitness. So can that apply to advanced nursing roles? Yeah, of course it can. It started off as an idea that was transmitted, word of mouth, conference proceedings, journal publications. Different people would look at that idea and think, oh, Yeah, that sounds quite interesting, quite good. Yeah, we could do something similar here. And maybe a little bit of variation starts creeping in. It may come about because it's a different context it's been put in. It may come about because you think, oh, we could tweak that, we can make that even better. Sometimes you get variation caused by a little bit of misunderstanding between the roles. So, but as it's copied and spread, you get this evolution. So looking at nurse practitioners in the early days, nurses have often unofficially treated patients. Think of the ward sister in days gone by who would be guiding the junior medical staff, or occasionally just doing it instead of them. Think about some of the small community hospitals and their casualty departments where there's no medical staff in the hospital. It's a GP somewhere else. Patient comes in, you look at them and think, I can sort you out, and they would sort them out and maybe tell the GP the next day, or just put something in the notes about it. So it used to go on as sort of unofficially, but the first sort of formal nurse practitioners, that concept evolved in the United States in the mid-1960s, in Colorado, where there was a distinct shortage of pediatricians. So the idea came about that we could take nurses, give them some additional training, prepare them as advanced nurse practitioners, or nurse practitioners as they called them then, and the role started to evolve. We crossed the border into Canada in the early 1970s, and the idea was translated to primary care and family health. And there were some big trials done. There's still some of the biggest trials of nurse practitioners to date in the world. And then the idea spread further. It took a little while to come across the pond to the UK. It was the mid-1980s. And the role really sort of developed within A&E and primary care. It took another 10 years to come north of the border here. And again, the idea is spread to lots of different areas. This wee graphic here is just to give you an indication of one of the roles. This is emergency nurse practitioner roles, and it's because I've got some data on it. And it shows the blue bars are the development of the role in England and Wales, but the darker sort of reddy brown colour is the role developing in Scotland. So you can see it sort of started 1994, the first 2 units, and then it's spread, and virtually all departments have got nurse practitioners working in them now. But what about other advancing nursing roles? In 2004, ISD, the Information and Statistics Division of NHS Scotland, National Services Scotland, started counting clinical nurse specialists. And I think Scotland was certainly the first country, or a UK country, it probably still is the only one that's counting clinical nurse specialists. And this is the definition. It's gone through a couple of tweaks over the years, and this is the current definition. So I'll let you read that. But you'll see it's quite broad, and the way that people are counted as clinical nurse specialists is essentially, if your line manager feels that you meet that definition, then your entry on SWIS, which is the Scottish Workforce Information Standard System, can be changed. So we drop down menu to CNS. And it's quite interesting from the work that Karen's done. The official number of clinical nurse specialists, according to ISD here in Grampian, was 176 in September last year, but you've found double that potential number. Same is true in Glasgow, and it became a bit of a standing joke actually. Every time I went to some national meeting, it was, so Mark, how many more clinical nurse specialists have you found in cupboards this week? Because it seemed that every time we went to try and count them, the number just went up and up and up. So looking at the official figures from ISD, when they started counting them in 2004 to the last published results at the September last year, you can see the top line is the NHS Scotland figures. NHS Glasgow and Clyde is this line, and the bottom line is Grampian. The missing data was simply because I couldn't find it online in the last few days when I was putting the slide together. But what I want you to look at is you can see how the number of clinical nurse specialists has doubled in that period of time. Part of that will be better reporting, but part of that I think demonstrates that there's been an increase in specialist roles over that period of time. Now you might look at the top line and think, oh, it's actually flattened off and maybe even decreasing slightly from about 2010. That's probably because that's when we started counting advanced nurse practitioners. So they go on to a different record there. Okay. So if we look at clinical nurse specialists, and bearing in mind it's about meeting that definition I showed you, in Scotland, in September, there were 2,285. We had a big chunk of them in Glasgow, and you've got a fair number of them up here in Grampian. If you look at the pay banding, half of them band 7, and about 2/5 of them are band 6, with a number of band 8, which range from 8A to 8C, and a few band 5s creeping in. Not very many band 5s. We took a decision in Glasgow that band 5 shouldn't appear on that at all. And so ours have been taken out. We looked at them first to make sure that they weren't clinical nurse specialists and took them out. But it's quite interesting how they keep creeping in. There's 3 have crept in the last few months, which we'll need looking at again and I suspect removing. We did a piece of work a few years ago, again, very, very similar piece of work to what Karen and colleagues have done here. And we looked at job titles as well. I haven't got that Wordle software, I need to find that. So I've just typed in a few of the ones that we've got. But again, it's a very similar range of titles, lots of different job titles reflecting, different roles that have evolved for different reasons and different ways. So why have these roles developed? Well, conditions. If we look at the conditions, there have been some very favourable conditions. I think within the profession, there's intrinsic factors within the profession, and there's been quite a lot of desire to see nursing develop and evolve. I certainly know when I was a junior staff nurse working in A&E, I used to get quite frustrated at times, particularly when I was in the minor side of the department. And I'd be triaging patients, and they would come in with various injuries and other things. And you would take a history from them, you'd make an assessment. If they needed pain relief, we'd have to send them around the corner to use agents to buy some paracetamol, because as a registered healthcare professional with 3 or 4 years training, wasn't allowed to give them paracetamol without prescription. That changed later with group protocols, and then more recently with the patient group directions. We could request x-rays and send them away for their films. And then we come back with their films in the packets, and because the waiting time was so long, we'd be curious about what you've sent them for us, and put the films up, interpret the films unofficially, because we had no formal training in that. But you got quite good at it over the years. And then the patient was sat there waiting for a member of junior medical staff to see them, who would then go through and take the history again and re-examine the patient, write up the notes, make a diagnosis that the vast majority of the time is the same one you come to. Occasionally there'll be a difference of opinion when you say, look, do you not think that's a fracture, or what do you think that wee line is there? And then with the treatment planning, again, you would be advising them more often than not in terms of how to manage certain minor injuries. So it got really, really frustrating, but 90% of that we could do. So the emergency nurse practitioner role, when it came in, allowed nurses to have a greater freedom, more responsibility. And I think a lot of nurses were very comfortable in doing that. So I think there was a desire within nursing to do that, certainly within my specialty, and I think we've seen that in lots of other specialties too. Service gaps. There's been growing service gaps in lots of different areas. There's increasing patient numbers. There's increasing complexity of patients as well as the population becomes more elderly with lots of comorbidities. There's far more clinical work out there than there has been in previous years. With a shortage of medical staff, partly caused by really exacerbated by the reduction in junior doctors' hours a few years ago, and that not being offset by the increased numbers in training. So you get that sort of artificial shortage. Has created gaps that have allowed different groups, including ourselves as nurses, to look at to see whether we can fill or help fill some of those. The expectations from patients have changed as well, haven't they? They expect a faster service, they expect a more efficient service, they expect a 24/7 service. They don't seem generally to mind who sees them, provided that person is competent and can give them what they need from that. There's also been some very positive policy developments. I've just put a few examples there, but there's many more. But these have helped, produce favourable conditions for the roles to develop. Scope of professional practice, when that came in 1992, really helped push and drive things forward, and there was a big increase in nurse practitioner roles at that point. Dispelling the myths has helped. Prescribing, bringing in prescribing, giving us that toolbox that we can use as again really helped develop the roles. And also reducing some of the regulatory barriers, the withdrawal of the extended roles guidance. I don't know if, well, I think probably a lot of people in the room will remember years and years ago, if you took on some extended roles, you had to get a ticket for that to allow you to do it, and the withdrawal of the guidance around that meant that we could push forward again. So there's been lots of favourable conditions to help the role evolve. I've also put at the very bottom there that no specific regulation around the role has helped too. When, I'm trying to remember, was it 2004? The NMC proposed that the advanced nurse practitioner roles should be regulated. There was a lot of consensus within the profession that was a good idea, and I was on that. I agreed with that. I thought that would be an excellent idea. It would help standardise things and take things forward. I am so glad now, in retrospect, that it didn't happen, because I think if it had happened at that point, we would have drawn a line in the sand and said, this is what an advanced nurse practitioner is, and we've been stuck with what the role was then. And I think things have really moved forward quite a lot in the last 10 years or so. I think it should come in at some point, but I'm glad it didn't happen then. So what? How is this model, how is thinking about advanced nurse practitioners in evolutionary terms helpful? I think it shows us that variation is essential, but where you've got completely unconstrained developments, you're going to get a huge variety, and some of those developments are going to be less hardy than others. They're not going to survive. They're not going to survive because service will change, will require different things, may not be as well prepared or whatever. So completely unconstrained developments going to give us some problems. If it's too constrained, you're going to get too little variation, and you're going to get risk as well. And potentially we could go the way of the dinosaurs. So some variation is absolutely essential. So I think the model's useful in that way, and it can also help us think about some of the risks. We can also think about succession planning and how the evolution of roles can help with that. So I want us to think a little bit about some engineering of this, some, I'm going to call it mimetic engineering. Because I think we need to think seriously about that with the roles that we've got at the moment. I think we've got over 100 different job titles now. We've got clinical nurse specialists, advanced nurse practitioners, and we've got a huge variety within each of those. And then we've got lots of other different roles too. So we need to define exactly what it is that we're looking for. I'll put that up there for a bit of a laugh. I also put it up there because I thought I would be quite worried if any of us as nurses couldn't see where we came from with that, because we're all in different roles, but we all have nursing as the core to that, and that's a very important element of who we are. So what is advanced practice? Eddie's talked to you in detail about the recent work with transforming nursing roles, and the ongoing work, I should say, with transforming nursing roles. Back in 5-10 years ago, in fact 2009 it started, work around modernising nursing careers. There was some consensus work then that really helped to take things forward with advanced practice. The product of that was the Advanced Nursing Practice Toolkit, which is done by Scotland on behalf of the UK. And you can look in particularly the Welsh and Northern Ireland work on advanced practice. You can see there's a heavy influence from this early work. And the same is true to some extent in England. From that, there was guidance to all the health boards on advanced nursing practice roles, and it's really on that work that the Transforming Nursing Roles work today is built on. So you'd have seen this definition from Eddie's talk about what an advanced nurse practitioner is today. It's helping to clarify things, a little bit of mimetic engineering around it, so we're all clear exactly what it is that we've got. In 2010, I mentioned in passing that ISD started to record advanced nurse practitioners and MMAP consultants. And the guidance to the boards was about how to identify these, and they had to be band 7 or above. They had to profile match or band match or exceed the Agenda for Change Nurse Advanced template, and they had to meet the definition of an ANP as set out in the Advanced Practice Toolkit at the time. So each board will have its own process to identify the roles. I thought I'd share with you the process that we have in Glasgow, and other boards won't be dissimilar. We have essentially a two-stage process. The first is identifying that the post is an advanced practice post. And that's done by looking to see, first of all, it's band 7 or above, that it meets or exceeds the job match for the Nurse Advanced template through Agenda for Change. And then when you look at the detail of the job description, it meets the definition of advanced nurse practitioner. That post then is an advanced nurse practitioner post. Doesn't mean the individual in the post is an advanced nurse practitioner, and that's the second stage of our process. And what we're doing is essentially looking to see that they've met the requirements for the knowledge, training and experience for the role as set out in the job description, which in future will probably mean a postgraduate diploma in advanced practice. So that's how we recognise our ANP roles. Within my board, we've got 85 ANPs formally recorded as being advanced nurse practitioners that have gone through that process. And they're in 14 different specialist areas. Our CNSs, many more of them. Some of those will include some ANPs that we haven't yet formally identified as being ANPs. It will also include some people that are working at the nurse practitioner, the level 6, band 6 role. And you can see the banding for the two roles there. All our ANPs are band 7 or above. 15% of them are band 8A. And our Band 8As are probably split between sort of a senior ANP post and a lead ANP post. I think we need to do a little bit of work around what exactly the difference is between those roles, and between the 8A and the 7. Our CNSs, majority of them are Band 7, nearly 60% are Band 7, about 40% are Band 6, and there's the odds 1 or 2 that are Band 8, A and B. That's not a completely dissimilar picture to what you have up here. So ANPs have really come a long way, even in the last 20 years. If we go back to the 1990s, there was a lot of in-house training going on. Often it was unaccredited, and then gradually it evolved into university-accredited modules for it, often at degree level, sometimes even at diploma level. But the scope of practice for those individuals was really quite limited when you compare it to today. When I started off in an emergency nurse practitioner role, did Eddie talk about the nurse that could see the big toe? Yeah. Well, I was that nurse. We could see patients with injuries that were distal to the knee and distal to the elbow, and head injuries. Didn't quite get that one, but anyway, so that's what we could see. I think it's probably a Glasgow thing, you know, what's the name? But anyway. So yeah, limited scope of practice then. We had no prescribing. Group protocols were sort of being used a wee bit at that point, but there was no formal prescribing. There was this, I still get it a wee bit today, don't you? This thought that this was a completely different role. This was not a nursing role. This was a mini doctor role, and you know, there were lots of discussions around that at that point. There's also relatively little evidence for the role. It was growing at the time, and there was some really good evidence from places like America and Canada for the role, but we had relatively little evidence here. And there were very few textbooks that were written specially for advanced nurse practitioners. So we're using medical textbooks, and you know, they were great, but they're written for a different audience. And there was a very mixed reception from nurses and doctors and other AHPs to the role. A lot of the resistance to the role developments actually came from within nursing. Medics were sometimes very vocal about it. Remember the junior medical staff, the SHOs in A&E, when the ANPs were first brought in, and the first cohort of them was like, hated them. Basically, they saw them as taking over their job. They changed 6 months later. The next lot came in. Fantastic, great. You know, we've got somebody we can work with who can, you know, seeing the same patients as we are. It gives us a little bit longer to spend with our patients when we're learning. Somebody we can ask questions to, and their reaction changed very quickly. And senior medical staff have changed as well. I think it's when people have been working with them for a while, they suddenly change and really like them and couldn't do without them, but sometimes it takes a little while to get there. So in the 2010s, we've got university and clinical education, master's degree programs that are often linked quite closely to clinical areas. We've got full master's programs in advanced practice. We've got a much wider scope of practice than we had 20 years ago. We've got full prescribing rights. I think there's only three medications that we can't prescribe. But essentially it's the whole of the BNF. We've got some clarity around this advanced nursing role and what that is. There's a much larger body of evidence to support the role. There's a growing number of textbooks that have been written by advanced nurse practitioners for advanced nurse practitioners. And it's just very much an essential part of the health service. Imagine if all of us stopped work tomorrow. There's a number of services that would fall down without advanced nurse practitioners and clinical nurse specialists. So the clinical role has really evolved. We've got now nurse-led units. In Glasgow, we've closed a number of A&E departments. We've just got nurse-led minor injury units instead. But we've got lots of nurse-led services that have taken on work that was previously done by medical staff. We've got them working alongside middle grade doctors and working on their rotas. Education, say, has really come forward with master's level courses, and moved away from in-house unaccredited leadership. We've got ANPs and lots of senior positions now. I think Eddie, a great example of how you can move on from advanced practice and go all the way to the top. We've got ACAP. Have you heard of ACAP? It's a group set up for advanced nurse practitioners in Scotland by advanced nurse practitioners, and they run conferences each year for ANPs, and they produce a journal as well for ANPs. And the RCN has had a very strong leadership role in the development of advanced practice too. From the research side of things, we've got books and papers published by ANPs. We've got an increased number of professional doctorates and PhDs, and a small but growing number of ANP-led research studies, and that's something I think as a group that we really need to do some more work on over the next few years. Still a long way to go. We've come up an awful long way, and we've still got a long way to go. And here's some of the challenges. Some of the challenges I think we've got. We've got greater movements towards a single vision of what an advanced nurse practitioner is. And we need to get that sort of Ronseal approach. So when you buy an ANP, you know exactly what you're getting. It does what it says on a tin. And I think we're getting there. The Transforming Nursing Roles work, I think, is really helping with that. But we need some more detail on what an ANP actually does. Do ANPs do the same things, but in different contexts? Or, because they're working in different specialties, are they doing very different things? So I think there's still some discussion, debate, and some clarification required around that. Scope of practice. It's now been made clear through the Transforming Nursing Roles that you need a full V300 to be an ANP, which is great. And that's something that we still need to work on and push forward with. Investigations. I came across a group of ANPs in Glasgow the other day that told me that they can't yet request x-rays. They put in the application forms for it, got knocked back, and then they didn't do anything about it. Thinking, if you need it for your job, then we need to sort that out. So we've got some battles to be had locally around sorting that out. But it's really frustrating. You've got these Band 7 masters educated ANPs that are not allowed to x-ray. Right next door, in the unit next door to them, there are Band 5s who are allowed to request x-rays with no or very little additional training compared to what the ANPs are. So we've got some things like that we need to get sorted out. Admission, discharge, referral, again, that's very variable from one area to another, so again, we need to have greater consistency around that. I think we need to give a little bit more thought around rotas and off-duties. Should ANPs be on medical rotas? Should medical staff be on nursing off-duty? Should it be a multidisciplinary rota that people are on? Other professional groups. There are other groups of staff that can do the same job. I showed you a picture of Stu Daly standing outside his helicopter. Well, he's working with paramedics that are doing exactly the same role as he does. Within minor injuries, we've got paramedics, we've got physiotherapists, and there's the odd radiographer that all do the same job. And advanced critical care practitioners. In England, there are some physiotherapists that do the same role. So you can take different healthcare professionals, give them the appropriate training, and they can do the same job. Should those individuals have the same title? So a nurse and a physiotherapist who are both working in ITU as an advanced practice role, should they be called advanced critical care practitioners, which is the term that's being used? Or should they retain their professional titles so that you've got an advanced nurse practitioner in critical care, you've got advanced physiotherapy practitioner in critical care. They are both advanced critical care practitioners, but they retain their professional titles so you know where they came from, and more importantly, which regulatory body they sit under for that. So I think there needs to be more discussion, debate, clarification around that. Otherwise, it's a bit of a slippery slope. ANP programs, said we've got lots of different master's programs out there that help educate ANPs. Great, that's fantastic. But we've got lots of issues and things with those as well. I met a couple of nurses the other day that told me very proudly that they'd just graduated with their MSc in, I think it was advancing practice or advancing nursing practice. Great. Didn't recognise them, so it's right. Where do you work? How long have you been an ANP for? No, we're actually looking for a job at the moment. Oh, right, okay. So where did you practice as an ANP? No, you don't understand. We're newly qualified, and we went and we were full-time doing this master's programme, and now we're looking for our first staff nurse job. And there are quite a few out there like that. But they've got exactly the same degree that we're encouraging our advanced nurse practitioners to obtain. So managers need to be aware, and practitioners need to be aware that that's the case. So what it says on the tin might not be what's exactly inside. Tuesday when I came up, I was working with a university looking at their program for advanced practice, and it's called Advancing Practice. And they said, well, there's different pathways you can do through it. And the one for ANPs is the clinical pathway. So it's very clearly labelled as the clinical pathway. Great. Looked at the content of their program, and yes, it's got everything in it that we'd expect. But the clinical assessment is optional. Non-medical prescribing is optional. So there's some challenges there. We need to get that sorted. Getting places on the program is becoming increasingly difficult. I don't know what it's like up here, getting on non-medical prescribing programs. But down in the central belt, it's about a year waiting list at the moment. So that needs to get sorted. That's despite capacity being increased. We're seeing a similar problem with accessing, generic clinical assessment courses as well. It's becoming more difficult. Then there's the transfer of credits. In theory, you can transfer credits between different universities, and it does work in practice to an extent. But we've got individual ANPs that have done courses at different universities, and they can't graduate with anything because they've got too many points from too many different universities. And even when somebody is aware of that and they do a number of modules at one university they're going to graduate from, and there's a particular specialist module at a different university that they need to do for their job, and they go and do that and they get the credits and they transfer them across. There's often problems with transferring the credits in terms of, they might get, say, 30 credits at this university, but when they transfer across, because they don't have exactly the same module shape and size, that they'll only get maybe 20 credits for it. So they're having to do more credits than they need for the programme. So we've got some things like that we need to look at and sort out. Supervision, something we need to look at in the clinical areas. Some areas it's really, really good, really robust. Other areas it can be improved. We need to look at the balance of the programmes. What I mean by that is when you look at the content of a programme, it might not reflect the job. The job of an ANP is generally about, well, often it's 100% clinical, but usually somewhere between 90 and 100% clinical, and the other 10% for all the other elements. But when you look at the master's programs, often 50% is research. 30 credit research module plus the 60 credit dissertation is 90 credits, and a full master's is 180 credits. Then you put in the leadership module, you put in the education module, and then you find that you've got a very small number of credits for the clinical component. That's not true of all the courses, but I think we do need to do a little bit of rebalancing of some of the, or many of the programs. Placements, we need to ensure that people get exposure, not just in the area they're going to work, but get exposure in other areas and work with other ANPs. Because I think you pick up a lot about the role, and you can pick up some good clinical tips and experience from that too. We need to have trainee posts, so you're not learning on the job in terms of, you're being put into an ANP post and having to try and deliver that service while trying to do the training, but actually move into a formal trainee post. So it's got trainee on your badge, everyone knows that you're a trainee. It's maybe for a 2-year period while you do your postgraduate diploma in advanced practice, and study time's built in, placements are built in, supervision's built in, and at the end of that trainee post you get rewarded with an increase in banding. So something called Annex U, have you heard of that? Agenda for Change. It allows you to take a post, say a Band 7 post, and convert it into a trainee post. You get a percentage of the salary, so it's sort of equivalent to a Band 6. While you're training, it goes up each year while you're doing the training. And it means at the end that when you complete and meet the requirements for that post, the post hasn't disappeared because you're already in it, and you get your full Band 7 salary. So we need to look at using things like that more. We need to look at backfill for trainees as well, because that tends to be one of the major stumbling blocks. Usually you can find money to pay university fees, but it's finding the funding for actually allowing people to go on the courses and for study leave is more of a problem. So should all ANPs have the same core knowledge and skills? I think there's two arguments. There's a yes and a no for that. For the yes side of things, the transferability, increased transferability, is going to give increased flexibility for the service if everybody's got a standardised training. Helps with the courses because they know exactly how many people are going to come and what they need to offer. It might take a bit longer to train folk, and there might be some things that you wouldn't use in your particular practice. On the no side of things, if you're doing a very specialised job and you're going and doing a generalist course, there's maybe lots of things that you wouldn't use. So that might be an argument against it. You're looking for individuals to meet very specific service needs, so there's an argument about why should we do additional training that's not directly relevant to filling that post. And often courses have been tailored for specific areas and to fill specific gaps. But then you have problems with sustainability of courses, although that approach is often quicker to train as well. So I think there's two sides of the argument there. I'm on the yes side, just sent my colours to the mast. But I think it's something, again, that we need to have a robust discussion around and make some decisions about where we need to go. So a few more challenges. The banding part, so minimum Band 7, line drawn in the sand back in 2010, fantastic. We need to see more ANP posts at levels above that, and we need to be clear what they look like. So senior practitioner post, the lead advanced nurse practitioner post, and the consultant ANP posts, what do they look like? Oops. You've seen this diagram before. This is just talking about how the role relates to other nursing roles. I remember years ago going to a meeting at Scottish Government, this is at the very beginning of the Modernising Nursing Careers work, and the room was full of clinical nurse specialists and senior nurse managers and directors of nursing, and there were two of us that had a sort of nurse practitioner background, and it was most of the meeting. It went on for about 3 hours. The room was packed, it was baking hot, was around where does the nurse practitioner role and the CNS role fit? Which one is more senior than the other? And the answer is that you've got a clinical nurse specialist posts working at different levels, and you have these nurse practitioner posts working at different levels. And from the nurse practitioner side of things, we've clarified that there's essentially two big levels of practice. You've got a nurse practitioner level at level 6 on the career framework, and you've got an advanced nurse practitioner role at a minimum of level 7 on the at level 7 on the career framework. And this diagram was developed by a guy, Dave Barton, down in Wales, and it very nicely articulated that advanced is on a spectrum from novice to expert, and specialist is on a completely different spectrum, on a specialist to generalist, and it depends on the context that you're working in. And I think that really helped clarify things for a bit, but there's still some confusion and some debate around that. And whilst we, I think, are clarifying exactly what the advanced nurse practitioner role is, I think we need to clarify exactly what the clinical nurse specialist role is. And things like the ISD definition, I think we need tightening up around that too. So looking at clinical nurse specialists and advanced nurse practitioners, at what we've got today, we've got CNSs predominantly working at band 5 to 7. That's with the caveat there are some 5s all the way to 8 Cs in Scotland. The education level is generally degree to masters, tend to have expertise in specialist areas. They tend to be clinicians, but often with a research or education function, and that can be quite variable depending on the roles. They may or may not be prescribers. They often run nurse-led clinics, and they often provide a service that's different to the service provided by other healthcare professionals. Bit of a generalisation, but 5 minutes. The advanced nurse practitioner, on the other hand, 7 to 8A, master's level qualification for entry, tends to be more of a generalist than a specialist area. As a clinician, prescriber, often delivers nurse-led services, and often provides a service that's similar to that provided by other healthcare professional groups. So that's my sort of summary of how I see the two roles at the moment. You may have very different roles, different views about that. It'd be good to have some discussion about that maybe this afternoon. But one of the things, or two of the questions it raises for me is, should CNSs be more like advanced nurse practitioners? Or should advanced nurse practitioners be more like CNSs? Or are they completely different, distinct entities? I think actually CNSs should be a bit more like ANPs, and ANPs should be a bit more like CNSs. I think there's more in common between the two than there are differences. There are exceptions to that. I think that ANPs should have more time for the other pillars of practice, because they tend to be 100% clinical. And I think there's things that ANPs are doing that clinical nurse specialists can do as well. So we can debate and discuss that later. Demographic time bomb. Looking at the ages for nursing staff. This is GGC figures. The green line at the bottom is our nursing workforce. And you can see there's a big bulge in the 50, around about the 50, late 40s to mid 50s mark. It's more pronounced in the clinical nurse specialists. It's even more pronounced in the advanced nurse practitioner group. We're going to lose a lot of ANPs over the next few years. We're going to lose a lot of CNSs over the next few years as well. Talking about evolution, saying competition will have an effect on the roles. The gap was partly created by a reduction in junior doctors' hours, so an increase in medical workforce is going to have a pressure on nursing roles, just as other professional groups that provide or can provide a similar service or the same service is also going to put pressure on the roles. We need to be aware of that, and we need to think about what's the added value that nurses bring to these roles. What makes us better at doing this part than other potential groups? Or maybe there's roles that we are not so good at doing, and maybe we just say, right, okay, that's actually better done by a physiotherapist, or that's actually better done by a paramedic. Just going to very quickly show you our vision in GGC, because I'm aware that I'm out of time. This is very much based on the Advanced Practice Toolkit, the Scottish Government guidance for advanced practice and the transforming nursing roles work. We see the ANP role as a nursing role, very much as a nursing role, but it should be more generic than it's been in the past. So we're looking at the same job description, the core competencies all fitting nicely in with the transforming nursing roles work. We're looking for greater ability to move between the different areas. We're already seeing that with a lot of ANPs, having worked in one area for a number of years, looking for a new challenge, and then moving from areas like acute medicine into acute oncology, to A&E and all sorts of things. There's increased movement there. We want to try and help and facilitate that. We're looking for a postgraduate diploma in advanced nursing practices. That being our main qualification for the role. Looking to see if we can put trainee posts in, for a 2-year period. Looking to clarify the difference between Band 7s and 8s as ANPs. Looking to improve supervision. Looking to put in an annual training needs analysis for all ANPs and a CPD program to support that. Looking to ensure that all the roles are doing an annual case note review around that. At the moment it's a bit patchy. Looking that all ANPs will eventually have 10% time for supporting professional activities, because they don't get that at the moment. Looking for the teams to produce some sort of annual report to evidence their contribution to service delivery and what the added value is of their role, and looking to evidence the impact of ANPs more. So we're progressing this at the moment. We've got an advanced practice group with chief nurses, professional nurse advisors, practice development, ANPs on it, that's trying to take this forward, well, is taking it forward. We've rewritten an advanced practice strategy with these aims in it. We've got a mechanism, as I've talked to you about recording ANPs, and we're continuing to record them. We're working at the moment at doing a generic job description for ANPs. We've identified funding, ring-fenced funding for advanced practice, for the course fees part, not the backfill. We're identifying and we've developed various educations to support that, and looking to promote the use of ANP training posts. So, final slide. The advanced nurse practitioner role is a role that's evolving and will continue to evolve over the next few years. Thinking of the ANP role as a MEM can help our understanding of how the role is changing and the influences on it. And we need to give careful thought to how we can select the best characteristics or engineer the role for the ideal attributes to make it strong and robust to survive future analyses. So that's me. Thank you very much.
Thank you very much, Mark. That's really interesting. Fascinating.